Welcome to The Explainer. Today we're jumping right into a concise refresher for experienced surgeons on the anatomical foundations of gastrectomy. We're going to get straight to the core principles that really govern our dissection planes and oncologic margins.
Okay, let's dive right into this question. The incredibly complex anatomy we navigate every single day, well, it all has its roots in this dramatic embryological spectacle shell. And understanding this blueprint isn't just for the academics, it's the absolute key to surgical precision and mastering those avascular planes we rely on.
So here's the game plan. We'll quickly trace that embryological blueprint. Then we'll build the anatomy layer by layer, kind of like a model. From there, we'll pinpoint the critical vascular zones, map out the lymph node stations that go with them, and then finally, we'll walk through the logical sequence and the tactical maneuvers of the procedure itself.
All right, let's start right at the beginning. The complex three-dimensional structure we see in the OR, it's not just there by chance. It's actually the end result of two major rotational events in fetal life that literally create the very planes we dissect.
Now, what's really fascinating here is how you have these two distinct rotations happening. You've got the stomach rotating clockwise, while the midgut rotates counterclockwise. And this forces what was once a simple flat sheet of mesentery to literally collide with itself and the posterior wall. That's what creates the complex, multi-layered omentum and the retroperitoneum we have to navigate.
And here is the direct result of those collisions: the formation of our key retroperitoneal dissection planes. You see the fusion fascia of Treitz on the right and Told on the left. They're not just random anatomical names. They literally represent fused peritoneal layers. Understanding this origin is fundamental, because when we mobilize these structures, we are essentially reversing that embryological fusion event. Let's build on that foundation. Instead of trying to picture this complex anatomy all at once, we can really simplify it by assembling the structures from the deepest layer to the most superficial, just like building a plastic model. It's a really powerful way to visualize all the spatial relationships.
Think about it. By starting with the great vessels, then draping the pancreas and duodenum over them, and then adding the mesenteric and peritoneal layers one by one, we get a crystal clear mental map. This step-by-step construction clarifies exactly how the pancreas relates to those vessels and how the omental bursa is formed, which is, absolutely crucial for orientation during the procedure.
With our model built, let's focus on the critical vascular intersections that define our dissection. Remember, these aren't just conduits for blood, they are the signposts, the landmarks for our lymphadenectomy. So while all of these landmarks are obviously important, recognizing the gastrocolic trunk of Henle is paramount. This venous landmark, where the right gastroepiploic and accessory right colic veins all converge into the SMV, is basically your gateway to accurately dissecting the number 6 and the 14V lymph node stations. It's a huge deal.
Now, let's see how this vascular anatomy maps directly to those critical lymph node stations for a D2 dissection. The best way to think about it is this: the vessels are the roads, and the lymph nodes are the towns all along them.
This table is really a high-yield summary of that map. You can see Station 6 is defined by the right gastroepiploic vessels and Henle's trunk. Station 8A follows the common hepatic artery. 12A is right there along the proper hepatic, and 14V tracks the SMV. Mastering the fascial boundaries that are defined by these reference vessels, well, that's the very essence of a precise oncologic resection.
Okay, so let's integrate all this anatomical knowledge into the logical, step-by-step sequence for a total gastrectomy. There's a method to the madness here that ensures a systematic and complete resection.
Following this logical sequence is really key. We start with broad exposure, then we mobilize the pancreas and spleen by getting into that plane of Told's fascia. From there, we systematically work our way around the pancreas. First, we address the infrapyloric region, then the suprapyloric, and finally the suprapancreatic vessels and nodes. This flow ensures a complete en-bloc lymphadenectomy before the specimen is even divided and removed. So let's zoom in on two essential maneuvers that rely heavily on these anatomical principles we've just reviewed. This is really where the theory meets the scalpel.
And this just brilliantly illustrates how a precise dissection requires navigating between multiple fused layers. After you detach the greater omentum from the transverse mesocolon, you then have to incise the fusion fascia on the anterior surface of the pancreas itself. And that's what allows us to isolate the correct mesenteric fat pad containing the number 6 nodes, all while respecting the very delicate pancreatic parenchyma.
So ultimately, the key takeaway is this:
Mastering these complex procedures goes so far beyond just memorizing steps. It's really about deeply understanding the anatomical blueprint that was laid down by embryology. That understanding is what allows for true adaptability and precision in the OR. And that concludes our refresher. But as a final thought, just consider how this embryological perspective might clarify other procedures we perform all the time, like a right hemicolectomy and the mobilization along Monk's white line. Applying this framework can offer some powerful new insights into techniques we thought we knew inside and out. Thank you for joining us.